Hello everyone, my name is Stephanie Wang and I'm from Montreal, Canada. Today I'll be presenting a case I like to call my worst nightmare. So this case starts with Miss P, a 74-year-old Caucasian woman from Montreal, who presents to the hospital in January 2023. She doesn't have many prior health issues or any particular risk factors. She's admitted in neurology for a 2-week history of a rapidly evolving cerebellar syndrome that includes ataxia, rotary vertigo, nausea, vomiting, and generalized fatigue. Her vital signs are normal, and besides a horizontal bilateral nystagmus and a slight right upper limb dysmetria, her physical exam is unremarkable. Her routine blood works are also normal, except for a slightly elevated C protein reactive test. Initial cerebral CT scan and MRI show non-specific cystic lesions in the right cerebellar hemisphere and vermis. 5 days later, a control MRI shows that the lesions are actually progressing into the left cerebellar hemisphere. Unsure of what nature these lesions are, a lumbar puncture is performed, but it's not very contributory. An extensive infectious and neoplastic workup is done on the CSF, but all is negative. A brain biopsy is done, and histopathology shows numerous granulomatosis, inflammatory infiltrates, and foci of acute inflammation with focal necrosis. These findings are suggestive of an infectious etiology, but no microorganisms were identified on staining and immunohistochemistry. So at this stage, the differential diagnosis of the cerebral granulomas is very large and can include neoplastic, infectious, or inflammatory nature. Additional workup for extensive infections and inflammatory diseases are done, but all are negative as well. So despite numerous negative tuberculosis cultures, the patient is empirically placed on quadrotherapy for tuberculosis, dexamethasone, and trimethoprim. She returns home after a good clinical improvement and 2 weeks in a rehab center. Her follow-up imaging also shows a marked improvement in the lesions. However, at the end of April, during her clinical follow-up, an acute hepatitis, most probably due to the isoniazid that she was taking, is diagnosed. As such, faced with the near resolution of the patient's neurological symptoms, the improvement in the cerebral MRI, and the lack of a frank diagnostic hypothesis, no treatment is reinitiated. Over the following week, the patient's liver function test improves. Unfortunately, just 1 week after this follow-up, the patient is readmitted in internal medicine for newly appearing dysphagia, aphasia, and right brachial facial paresis in 48 hours. Control MRI shows that multiple new masses appeared in just a few days, affecting all lobes as well as the brainstem. In this situation, all infectious and inflammatory and neoplastic workup is redone. However, there's still no frank new diagnosis. We suspect maybe a lymphoma. No treatment is reinitiated while waiting for a second brain biopsy, which is finally done urgently after a rapid deterioration in the patient's state of consciousness. Afterwards, the patient is transferred to the ICU. Now, what do you see from this histopathology slide? What if we got closer? And what if I asked you, what are these blobs? Well, finally, the neuropathologist identifies a free-living amoeba, the Canth amoeba. The Canth amoeba is one of 3 free-living amoebas known to cause infections in humans, the other 2 being Balanusia mandralaris and Naegleria fowleri. These amoebas are ubiquitous in nature and can be found in air, soil, and water, and humans can get infected through open wounds, ingestion, or inhalation. Specifically, the Canth amoeba can cause 3 distinct clinical syndromes, one of which is called granulomatosis amoebic encephalitis, or GAE. GAE is defined as a subacute to chronic meningeal encephalitis, and definitive diagnosis is made by tissue examination, rarely by CSF analysis. It's important to note that these findings, the histopathological findings, are highly variable, and they show signs of an amoebic infection, but does not allow us to differentiate the type of amoeba. In order to do so, immunohistochemistry, immunofluorescence, or PCR is needed. In our case, the specimen is sent to a reference lab in the United States for final identification. Given the lack of cases reported and the lack of literature on treatment, there's no specific drug therapy to be found. However, early treatment has been associated with better survival. In our case, 6 drugs were prescribed, but unfortunately, faced with lack of improvement and the poor prognosis, comfort care is undertaken and the patient dies quickly. A few weeks later, the species of amoeba is confirmed to be an acanthamoeba species. So in conclusion, there are 3 free-living amoebas known to cause infections in humans, and although there's no specific drug therapy found to be superior, early treatment has been associated with better survival, hence the importance of a rapid diagnosis. In order to do so, clinicians must be more familiar with this disease, know the clinical presentation of GAE, and be ready to discuss with various specialists involved when the microorganism is suspected, even if there is no real risk factors, such as the case in Ms. P. In the case of Ms. P, the questions remain for where, how, and why she got this brain-eating amoeba. Truly something from my worst nightmare. Thank you.
Well, this was truly fascinating. Every time I hear about a new disease, which I have to know and consider and never heard about for the last 40 years, it frankly raises my level of anxiety quite high. Where is this organism present? Where is it? In Montreal, or was there a travel?
This is a question that we asked ourselves, because when we reviewed the literature, the most number of cases that were reported were mostly in the Great Lakes of the United States, and they were not known to be in the Quebec province from Canada. So when questioning the patient, we had asked, where have you traveled? Have you been to the United States? And she has not really traveled anywhere else out of Quebec.
Did she have 2 brain biopsies or 1?
She had 2. Exactly.
And on the first one, they didn't find what they found?
Excellent question. When we found the amoebas in the second brain biopsy, our neuropathologists even went back to review the first pathologies, and they saw that there were some cells that may be, in retrospect, suspicious of amoeba, but because in the initial differential diagnosis we didn't think of it, they misidentified them as macrophages or as neurons.
Well, in retrospect, everything is easy.
Yes.
I asked the easy questions, and Professor Nishma Singhal is our content expert. Nishma, I'll ask you for a comment here. A fascinating case.
Thank you.
I will also preface this with that I am not a consent expert in amoebic encephalitis, in that these cases are obviously extremely rare. They're definitely on a differential. I actually had a couple of questions, just really curious about, was there any hypotheses about why the MRI and the patient initially clinically improved? Do you think it was a steroid effect, or was it something else? I know they were on septic prophylaxis, and that could be part of the treatment, but they were on a pretty low dose, so I can't imagine that was the...
Excellent question as well. We also had asked ourselves the question. Initially, we had suspected that it was the dexamethasone that helped, which is why the second time around when the patient presented again, we thought it might be a lymphoma that responded to the dexamethasone. However, once we had the confirmation that it was an amoeba, we actually think that amongst the 4 drugs in the quadrotherapy for tuberculosis, we suspect that it was probably the rifampin that actually helped. By which mechanism specifically, we're not quite sure, but from the literature we found, there were some combinations of effective treatment that included rifampin. It was a bit more prevalent in our review of the literature.
And just
questions from the floor are also welcome.
I'm happy to pass it on.
Congratulations for a beautiful case. It's not a question, it actually is a comment. In the last 8 months, we've had 2 cases of acanthamoeba encephalitis, one of a middle-aged lady, and she is alive and doing well. However, with a combination of all sorts of drugs like antibiotics, antifungals, and antiprotozoals. So it is very difficult to actually see how these patients will be faring in the long run. And it is also for us to be aware that when we do not find the etiology of a particular encephalitis, we should be looking for these, because somehow, I do not know why, these organisms are now being increasingly diagnosed. And we did not have resource to a brain biopsy, and it was diagnosed from a wet mount from the CSF itself. So thank you for this beautiful.
Excellent presentation. Did you do an autopsy to find out where else in the body was this amoeba, or how did it get in the brain?
Also, excellent question. Yes, the family did accept an autopsy, and the official autopsy report we got is that it was purely located in the CNS. There was no other sites infected.
Well, we've learned something new. Any other pressing question? It was fascinating. Thank you very much.
Thank you so much.